Welcome, everyone. This is Asa Carter. I'm the Senior Manager for the Education and Training session of ACS Cancer Programs, and I'm thrilled to be able to welcome you to our webinar this afternoon, Technical Standards for Thyroid Surgery. Next slide, please. A few logistics before we actually start the webinar. As you heard from the announcement, all of our participants, are muted during the webinar. Because of that, we ask you to submit your questions through the question pane that you'll find on the control panel. It usually appears on the right-hand side of your screen. Just click in that area and add your question there. You can include technical questions such as I can't hear, or I can't see, or I'm having a problem. We have staff standing by to respond to those questions, as well as submitting your questions about the content of the webinar. Questions will be answered as time permits, and any additional questions and answers will be posted to the website following the webinar. We ask you to please complete our post-webinar evaluation so that we can get information about what you liked, what you didn't like, and how we can improve our future webinars. The content is being recorded, and this will be posted on the Learning Management System 1 to 2 weeks following the conclusion of the live presentation. So with that, I'm going to turn the webinar over to one of our moderators for today, Dr. Elizabeth Grubbs. Dr. Grubbs, it's all yours.
Thank you. Good afternoon, everyone. Just a reminder that this will be available to receive CME credits. All attendees will receive an email from the vendorconfex.com to claim CME, which could be a 1.5 credit claim. All attendees are going to have 60 days to claim this, so please claim your CME credit by July 24th of this year. Next slide. In terms of disclosures, go to the next slide. The moderators, Libby Grubbs, receives institutional funds from Eli Lilly and Exelixis, and Mark Zafereo, his institution of MD Anderson, receives research funding from Mark and Eli Lilly, and none of the other panelists today have disclosures. I'll pass it off to Tracy.
Thanks, Libby. So our program objectives for today is that we will be discussing the preoperative and intraoperative considerations for surgical planning of thyroidectomy and lymphadenectomy for patients with differentiated thyroid cancer, as described in the Operative Standards for Cancer Surgery, Volume 2. So upon completion, we hope that everyone joining today will be able to describe the preoperative evaluation from pertinent history and physical exam, imaging, and laboratory tests, discuss the optimal surgery in patients with differentiated thyroid cancer, including the extent of surgery and management of lymph nodes, and then describe best practices in managing the recurrent laryngeal nerve and parathyroid glands. Next slide, please. So it's my pleasure to introduce our speakers today. So I'm Tracy Wang. I'm an endocrine surgeon at the Medical College of Wisconsin. I'll be co-moderating with Dr. Grubbs, who's an endocrine surgeon at the trying to bring you here at MD Anderson Cancer Center. I'm going to introduce all 4 speakers today and then turn it over to Dr. Yip. So Dr. Linwah Yip is an associate professor of surgery and chief of endocrine surgery at the University of Pittsburgh. Dr. Julie McGill currently works at the Emory Healthcare in Atlanta, Georgia, and is a fellowship-trained endocrine surgeon with 15 years of clinical experience. Dr. Mark Zafereo is a professor of head and neck surgery at MD Anderson Cancer Center in Houston, Texas. He's also section chief of head and neck endocrine surgery and associate medical director of the Head and Neck Center. And then lastly, Dr. David Hughes is a James Linds Professor of Surgery and Associate Professor of Surgery at the University of Michigan. He's also the Program Director for the General Surgery Residency and Endocrine Surgery Fellowship Training Programs. And we will save all questions until the end and after all of our panelists have spoken. And with that, I'll turn it over to Dr. Yip.
Great, thank you very much. So I'll be covering the preoperative considerations for surgical planning. Next slide, please. And so we make the assumption when we put this chapter together that we're talking about biopsy-proven papillary thyroid cancer over 1 centimeter. There's a lot of controversy and options in terms of management of papillary thyroid cancers less than 1 centimeter, so we really didn't talk too much about that in this particular chapter. And the goal with the management of these patients is to, number one, limit any operative complications, because we know that many of these patients will live for many years, and so we want to optimize their quality of life. And then number two, we want to minimize local regional recurrence. Next click. Thank you. And so in considering how to manage these patients, and you'll hear a little bit more about this in the later slides, it's really important to understand the staging. And so the most common staging system that we use is the AJCC TNM 8th edition. And this really stratifies stage 1 as being less than 55 years. And the only thing that really changes this stage for younger patients is if there's distant metastases. In older patients, nodal disease, large tumors, gross extrathyroidal extension, and distant metastases can really alter the stage. AJCC, as we all know, risk stratifies for disease-specific survival. Most of our patients with papillary thyroid cancer do not die from their disease, and so this, to some extent, is not as useful for prognostication for the majority of our patients. Next slide. And so we really think about recurrence, and that's what we want to avoid, as we had mentioned earlier. And we typically use the ATA risk stratification to separate thyroid cancers into low, intermediate, and high risk of recurrence as seen here. And for the most part, for most of our patients, the high recurrence are the ones that we would see on preoperative testing, right? So these are patients with gross extrathyroidal extension, incomplete tumor resection, distant metastases, and bulky lymphadenopathy. The criteria that separate low and intermediate are usually a bit more nuanced and typically found only after histology. And so you can see here the recurrence rates 1 to 2% for low, all the way up to 20 to 30% for high. And why does this make a difference? Next slide, please. That it changes how we think about the initial management of the patients. So patients with low risk thyroid cancers can be managed by initial lobectomy because they often do not need radioactive iodine, whereas of course those patients who are at high risk for cancer of recurrence would benefit most from total thyroidectomy followed by radioactive iodine. And so all of what we do preoperatively is to try to risk stratify patients as best as we can based on the testing and physical exam. Next slide. And so when I see patients in the office, it's important to assess from a history standpoint any signs or symptoms of advanced disease. So things like voice changes, these patients would need a preoperative voice assessment. Many patients have some degree of dysphagia, but we're really looking for true dysphagia or dynaphagia, which may be a sign of advanced local disease or esophageal involvement. May need additional testing. And then the presence of hemoptysis could herald tracheal invasion, and thus these patients would also need further evaluation. Next slide. Additional factors that we look for during the initial patient history is any prior history of neck or chest surgery, because this does put the recurrent laryngeal nerve potentially at risk. So types of surgeries that we often see are anterior cervical disc fusions, cabbage, open heart surgery. Those could potentially cause existing nerve issues. Prior external beam radiation, especially in pediatric patients, can increase the likelihood of cancer as well as multifocal cancers. Patients who have had a history of gastric bypass surgery or other types of malabsorptive conditions may be at risk for calcium malabsorption and subsequent issues with hypocalcemia after surgery. And so some of these patients would be best served by repletion of vitamin D and calcium prior to surgery. And then any family history of thyroid cancers or other related endocrinopathies, such as pheochromocytoma, maybe primary hyperpara, that may also impact your evaluation and extent of surgery. Next slide. On physical exam, really looking for reasons why surgery could potentially be difficult or things that could alter your extent of surgery at the time of the first procedure. So on palpation of the thyroid, is the nodule fixed or mobile? Fixed nodules, of course, are more concerning for malignancy and may herald a little bit more of a difficult dissection. Is there substernal extension? So often we extend the neck and have the patients lay down and try to feel the inferior aspect of the thyroid. and also whether the gland is large versus small, and sort of the texture of the gland can sometimes be helpful for deciding if this is going to be a more difficult procedure. Usually a good physical exam of the nodal basins to assess for lymphadenopathy, and of course the voice quality at the time of the initial evaluation. The presence of cervical incisions can also, of course, be helpful. You may ask the patient whether or not they've had surgery before, but they often may not remember what they've had done in the past, and so it's helpful to see that. And of course, just seeing if there is adequate neck extension at the time of the initial assessment, and the BMI and where that body mass is distributed is also helpful at the initial evaluation. Next slide. Laboratory studies, the only essential labs are a TSH to confirm euthyroidism. And then I usually will also assess vitamin D, calcium, parathyroid levels. These are sometimes optional, but about 3 to 5% of patients with thyroid nodules can also present with primary hyperparathyroidism, and often that's helpful to know going into surgery. In addition, that vitamin D can sometimes need to be repleted prior to surgery. Next slide. Cervical ultrasound is really the gold standard. And again, we're talking about patients who already have an existing diagnosis of thyroid cancer. So we're not really going to discuss too much about nodule risk assessment. But prior to surgery, we really need to make sure that the lymph nodes are adequately assessed. In addition, it's helpful to also take a good look at that nodule and that relationship with that nodule, the strap muscle and trachea, and is there any evidence of extrathyroidal extension? Next slide. So this is one example of a nodule that was biopsied positive cancer, which has a little bit of a fuzzy border between the nodule itself and the strap muscle overlying it. Next slide. And similar thing here, again, a little bit of a questionable presence of extrathyroidal extension. Next slide. In addition, it's helpful to look at the pathology in the contralateral lobe. Sometimes that can help you decide lobe versus total. And as we mentioned, any abnormal lymphadenopathy and biopsy, this will be covered a little bit further more later on in the hour. But lymph nodes are usually biopsied if the results will change management. Next slide. This is an example of some abnormal lymphadenopathy and the lateral compartment. Next slide. Next slide. Sorry. And then finally, cross-sectional imaging is helpful if there's any concern for substernal extension on the preoperative physical exam. In addition, if patients present with bulky lymphadenopathy, it's helpful to get cross-sectional imaging with IV contrast to be able to really get a good look at the relationship of these lymph nodes to the major structures such as the carotid artery, the internal jugular vein. In addition, for some of these patients with bulky lymphadenopathy, I do sometimes like to get cross-sectional imaging to see if there's any presence of mediastinal lymphadenopathy that is sometimes a little easier to resect at the time of the initial operation. In addition, cross-sectional imaging is often better in terms of assessing tracheal and esophageal invasion. Next step. And I think the most important thing is really multidisciplinary care and understanding the practice patterns of the team, including your endocrinologists that you work with, medical oncologists, radiation oncologists, and this can really help decide the treatment and surveillance. If the endocrinologist is not wanting to think about lobectomy for potentially larger cancers, then it really doesn't make any sense to have this discussion with the patient. And I really think that in this day and age, multidisciplinary care is really necessary if patients present with local, regionally advanced or invasive cancers. It's not just the subspecialty expertise using the assistance of thoracic surgery, for example, for locally invasive surgery, local invasive tumors, but also really consideration for neoadjuvant options, which are increasingly effective in some of our more advanced cases. So I'm going to stop there and hand it over to Julie McGill. Thank you.
Thank you. I'd like to start by reviewing the critical elements of thyroid surgery. The priority is a complete extracapsular dissection of the thyroid with identification and preservation of both the parathyroid glands as well as the recurrent laryngeal nerves. And an in-block resection of locally advanced thyroid cancer should be performed. Next slide. In 2015, the American Thyroid Association published management guidelines of thyroid nodules and differentiated thyroid cancer, recommending a shift to a less aggressive diagnostic, surgical, and postoperative treatment strategy. Next slide. This table summarizes these recommendations. In small, less than 1 centimeter cancers with no extrathyroidal extension, no vascular invasion, and no lymph nodes, a lobectomy is the appropriate surgery. New in this set of guidelines as compared to the 2009 guidelines, for cancers between 1 and 4 centimeters, they gave a lobectomy as an option, assuming there was no gross extrathyroidal extension, no clinically involved lymph nodes, and no aggressive histology. But they did note a lobectomy or total thyroidectomy could be performed. And in tumors greater than 4 centimeters, or those with gross extrathyroidal extension, clinically apparent lymph nodes, or distant metastatic disease, a total thyroidectomy was recommended. Next slide. These guidelines were published in October of 2015, and this graph shows the trend in total thyroidectomy proportions. This was both for benign and malignant disease, but you can see it was trending upward, likely related to the 2009 guidelines, but there was an inflection point with a change point in November of 2015, 1 month after the guidelines, showing the substantial impact of these guidelines. Next slide. And a paper in Thyroid published in 2021 showed that while in the beginning of 2015, 15% of patients with thyroid cancer underwent lobectomies, 3 years later, by 2018, up to 28% of patients with differentiated thyroid cancers were having thyroid lobectomies. Next slide. When we look at complication rates, there were statistically significant better rates when you looked at a lobectomy compared with a thyroidectomy in multiple parameters. So the lobectomy patients, 3.7% of them needed parathyroid autotransplants, whereas 10.6% of the total thyroidectomy patients. Less than 0.6% of the lobectomy patients had postoperative hypoparathyroidism, whereas 6.8% of the total thyroidectomy patients had postoperative hypoparathyroidism. And there was a statistically significant difference in the postoperative emergency room visits in the lobectomy patients at 2.3% versus the total thyroidectomy patients at 3.7%. Overall, when we look at it, this graph shows that the choice of a total thyroidectomy versus a thyroid lobectomy has little effect on the risk of thyroid cancer-related death. Next slide. So when we look at the pros and cons of doing a thyroid lobectomy, the pros are that the contralateral nerve is not involved and there's very low risk of a contralateral nerve injury. There's decreased risks of permanent hypoparathyroidism as well as transient hypoparathyroidism, and there's decreased need for thyroid hormone supplementation. The cons are it is difficult to follow the postoperative thyroid globulin levels, and they're not very consistent in lobectomy patients. And there is a need in a subset of patients to perform a completion thyroidectomy based on final pathology evaluations. The argument thus for a thyroid lobectomy is there is an equivalent long-term oncologic outcome for these low-risk cancers and short-term superior outcomes in terms of cost, thyroid hormone supplementation, hypoparathyroidism, and emergency room visits. I'm going to turn it over to Mark.
So continuing with the discussion of Dr. McGill, who eloquently outlined sort of the trend in moving from more total thyroidectomies to more thyroid lobectomies and why. We want to talk briefly about what are the cases where a total thyroidectomy may be necessary and what are some of the considerations. And two of those, just to mention, are extrathyroidal extension and lymph node metastasis, and we'll talk about each of those briefly. Next slide. So this was a study that we published in Annals of Surgical Oncology. It's been about 6 years ago now. Dr. McGill mentioned well that the staging recently changed with the 8th edition of thyroid cancer. And one of the changes that was made was the strap muscle invasion was now included as a factor for T3B staging. I think that's something that we need to continue to critically look at. In this particular study, we actually did not find a difference between patients. This was a study of 2,000 patients with less than 4 centimeter differentiated thyroid cancer. We did not find a difference between patients who had perithyroidal soft tissue extension and those who had strap muscle invasion. Next slide. And one of the things I think we want to keep in mind is where that extrathyroidal extension is located. When we're talking about anterior versus posterior extension, which is essentially involving the strap muscle, we inherently know as surgeons that this can be resected in block with minimal added surgical morbidity. Whereas the posterior extension, as you can see in these pictures, where it's abutting the trachea or the recurrent laryngeal nerve, oftentimes we're going to have very close, if not positive, margins there in order to try to preserve those critical structures. Next slide. So I think overall, one philosophy that I think is a good one is that if there's anterior extension involving the straps, it's generally still okay to consider a thyroid lobectomy, depending on the circumstances. Whereas if there's posterior extension where the nerve and the trachea are going to be with close margins or microscopically positive margins, then there's going to be increased recurrence risk. Those are the patients we're going to want to get radioactive iodine for, and we're probably going to want to steer more toward total thyroidectomies in those patients. Next slide. So the next thing to consider is lymph node metastases. So this was a study that we published about 6 years ago, looking at lymph node density and survival in patients with papillary thyroid cancer, about 2,500 patients. Next slide. And we did see a difference in terms of survival overall and disease-specific survival in patients who had significant lymph node dissections, and they had a lymph node density greater than 20%. So greater than, on average, 20% of lymph nodes that were positive, those patients had a higher recurrence risk. Next slide. But I think more importantly than that, we have to think about micro versus macro metastasis. This was a study that was published from a Korean group several years ago, and they really broke it down from no metastasis to micro to macro metastasis. And as you can see from the graph, the curves, you don't see any difference between no metastasis and micro metastasis in terms of recurrence risk, disease-free survival. But then when you get to the macro metastasis, you do see a risk. But when you look at really where that risk is, if you go down to the table at the bottom, it's really in terms of the lateral neck. So, which is not something that you can really change by doing a thyroid lobectomy or a total thyroidectomy. So I think if we go to the next slide, one way to think about it is if we have microscopic lymph node metastasis and there are few of them, I don't think a total thyroidectomy is required. I think those patients can often do well with a thyroid lobectomy. If they're macroscopic lymph node metastasis that you can see preoperatively on an ultrasound, or if there's many of them, you're often going to be moving toward a total thyroidectomy. Next slide. So I think in the absence of significant gross posterior extrathyroidal extension or macroscopic central compartment lymph node metastasis, most patients with less than 4 centimeter PTC should undergo a thyroid lobectomy. Next slide. Of course, unless the endocrinologist or patient have strong preferences otherwise. Next slide. Just to mention in a minute or two, a couple of specific cases where we often we know where we will be doing a total thyroidectomy. One is tracheal invasion. I think just to remind everyone that there are different classifications of tracheal invasion, the Shin classification or the Grillo classification, where you have, you can see in the pictures here, stage 1 to 4, from stage 1 being abutting the perichondrium, stage 2 invading between the rings, stage 3 into the lamina propria submucosally, but not elevating or invading the epithelium on the inside. And then stage 4 is when you can actually see it through a bronchoscopy, extending full thickness involving the mucosa. Next slide. So when we do these, we're going to obviously want to be doing a total thyroidectomy. We're going to want to remove all gross disease. We can tolerate a microscopic margin, positive margin in some cases. For the Shin 1 that are involving the perichondrium, tracheal shave is perfectly appropriate. For a Shin 3 or 4, where it's submucosal or tracheal lumen, we're going to need to do tracheal resections for those patients. And the Shin 2 is where you have a little bit of controversy where, or gray area, where sometimes you can do a shave and sometimes you need to do a tracheal resection depending on the clinical scenario. Next slide. So this is an example of a shave resection for a patient with Shin 2 involvement where it's extending between the tracheal rings here. And you can see the ridges of tumor on the actual specimen where the tumor was extending between the rings. And in some cases, as in this case, if it's, for example, an older patient, you can consider a shave in these patients. Next slide. This is an example of intraluminal involvement. You can see the tumor inside the trachea, where you're going to need to do a segmental tracheal resection. You can resect up to about 5 rings, but when you get to 3, 4, and 5 rings, often you need to do tension releasing maneuvers, including a mediastinal tracheal release, or sometimes a supralaryngeal release. Next slide. A couple things to mention when you're doing a segmental tracheal resection. The surgeon wants to control the endotracheal tube, so prepping that into the tube. We mentioned minimizing tension on the tracheal anastomosis. You can release the trachea inferiorly by just using finger dissection into the superior mediastinum. And then less commonly, you'll need a suprahyoid muscle release. These patients are going to have dysphagia associated with that suprahyoid release. And Grillo stitch, the chin to chest suture is an option, but generally not necessary. In terms of a trach tube, we try to avoid them if possible, as long as we are able to maintain one intact recurrent laryngeal nerve. And although sometimes we do need to do a tracheostomy tube if both recurrent laryngeal nerves are compromised. And then immediate extubation is preferred, except in the patients who have a tracheostomy who do not need extubation. Next slide. So this is we presented this at H&S last year, looking at our overall survival and local regional control, looking at 110 patients with tracheal resection, and we can get pretty good outcomes. This is across all pathologies in terms of survival and local regional control with tracheal resection. Next slide. The last thing to mention briefly is esophageal invasion. Again, often with this, we're going to be doing the total thyroidectomy. It often occurs concomitantly with tracheal invasion. But I think the important thing to remember with esophageal invasion, unless the patient presents with significant dysphagia, is it's usually just involving this outer muscularis layer. It's usually not involving the mucosa or even the lamina propria. Next slide. This is an example of when we're doing a total thyroidectomy, if there is posterior extension involving the esophageal muscularis, we can resect that muscle layer off of the esophagus, basically separating the mucosa and the lamina propria in a nice plane from the esophageal muscularis and resecting that in block with the thyroid, or sometimes resecting that separately. Next slide. And this takes us back to Dr. McGill and a quick case presentation.
So, Mark, this is going to be one of these patients comes in, 38-year-old woman. Her gynecologist noted some neck fullness, performed labs, and the thyroid function labs were normal, and did an ultrasound. And the ultrasound showed a 2.3 centimeter left thyroid nodule. An FNA was done, and it showed classical type papillary thyroid carcinoma. And so with this, when would you be thinking a lobectomy versus a total thyroidectomy?
Well, I think in this case, Dr. McGill, so looking at the ultrasound, it doesn't look like this is a patient who's going to have significant posterior extrathroidal extension, although this is just one shot here. Of course, it is a little bit close to the anterior, margin of the strap, and there could be some, microscopic abutment of the strap muscle there. But so in terms of extrathroidal extension, I think this case would be perfectly appropriate for a lobectomy. I think we would want to look at lymph node metastasis. Obviously, if we had macroscopic lymph node metastasis that were were evident on ultrasound and obvious in the central compartment or, of course, the lateral neck, most of those patients are going to undergo a total thyroidectomy. And then I think the other thing that I didn't mention in the talk is really looking at the contralateral lobe. I think, you know, we have specific criteria for TI-RADS and ATA status for when to biopsy thyroid nodules, but I think it changes a little bit when you're already dealing with the cancer on one side, because then you're trying to really determine if you can watch the other side. If active surveillance of the contralateral side is going to be appropriate long term, and we may have a little bit of a lower threshold to biopsy, you know, contralateral nodules in that case, if we know we're already going to be doing a thyroid lobectomy, just to rule out, you know, a cancer in the contralateral side if there is a nodule over there. And if there is a Bethesda 3 or 4 nodule, then, you know, that brings into question the possibility of molecular testing in patient discussion. You know, sometimes, you know, patients are going to want to be aggressive about trying to preserve that thyroid lobe, even if they have a indeterminate thyroid nodule on the other side. And sometimes patients are going to want to take the whole gland down. So those are some of the considerations.
Perfect. Thank you. Dave is now up next.
Great, thank you, Julie and Mark. I learned a lot from those cases. So it's my pleasure now to discuss lymphadenectomy for patients with regionally advanced thyroid cancer. I'm going to use a case to help demonstrate some of the concepts here, and we'll discuss many of the technical considerations when performing lymphadenectomy for metastatic thyroid cancer. So the ACS operative standards for thyroid cancer include recommendations for resection of metastatic lymph nodes in both the central compartment and the lateral compartment. It also further discusses how to manage recurrent laryngeal nerve when it's involved with metastatic lymph nodes with extranodal extension. So we're also going to cover the surgical approach to metastatic lymph nodes in the lateral neck, both with and without extranodal extension. Next slide, please. So in order to demonstrate the surgical decision-making in patients with regionally advanced metastatic thyroid cancer, I put together the following case. This is a 42-year-old female. She presents with a left lateral neck mass, which is underlying the sternocleidomastoid muscle. On exam, there are multiple enlarged lymph nodes which are palpable in the left lateral neck. She is euthyroid with a normal TSH. A cervical ultrasound has been ordered, which notes a small left thyroid nodule. The nodule in the thyroid is hypoechoic, it's solid, there's some internal microcalcifications, and it has some ultrasound features which are suspicious for papillary thyroid cancer. Additionally, there are multiple enlarged and abnormal appearing lymph nodes in the left lateral neck. They have both cystic changes and some microcalcifications, which we'll show in a minute. Next slide, Liz. So on the still images on the left, here are some representative ultrasound pictures of normal lymph nodes. In the left upper hand panel there's a lymph node with a nice oblong shape. It's wider than it is tall. And there's a lymphovascular hilar stripe, which is consistent with a normal lymph node. Can you go back one slide, Liz? On the Doppler slide, you can see there's vascular flow just in the normal lymph node rather than in the entire lymph node. In the two still image panels on the left, these are both metastatic lymph nodes. When metastatic lymph nodes are interrogated with a Doppler, they tend to have hypervascular flow throughout the entire lymph node and not just isolated to the lymphovascular hilum. The still image on the right shows a metastatic lymph node. It's solid, it's hypoechoic, it's become more rounded in appearance, and there are some microcalcifications present, which is typical of metastatic papillary thyroid cancer. Liz, can you have that video run through one more time on the left there? This is the ultrasound of the example case. You can see all the cystic changes in the multiply enlarged lymph nodes in the left lateral neck. These have a very characteristic ultrasound appearance of a thyroid cancer. It is crucially important to examine both the central and lateral neck in a patient that has thyroid cancer to confirm when you need to do a lymphadenectomy. Next slide, Liz. So I'll move back to our patient again. The patient then underwent an ultrasound-guided FNA biopsy of one of those left level 3 lymph nodes. The FNA was positive on cytology. Doing an aspirate washout with thyroglobulin can be helpful in metastatic lymph nodes. Oftentimes, especially if there's cystic changes to the lymph nodes, the FNA will be acellular. If the thyroglobulin washout shows a very high level of thyroglobulin, that's diagnostic of a metastatic lymph node. It is important to get CT scans of the neck When patients have a high degree of cervical lymph node metastasis, it can really help delineate the extent of disease and help with operative planning. Next slide. So this is the CT scan of the example patient. Over on the left-hand side is a cine loop that shows multiple metastatic lymph nodes in the left lateral neck. They're outlined there with the yellow highlighters. What the CT scan also shows is a metastatic lymph node in right level 4. It's a little bit more subtle. This wasn't really called out on the preoperative ultrasound. So this kind of goes to show that CT scans on that can be very helpful in determining the extent of disease when people will have multiple metastatic lymph nodes. The panel on the right-hand side just shows that in the same still image. These are some representative slices that are included in the ACS Operative Standards of CT scans that can do a better job of evaluating the central neck. Especially the low central neck is a blind spot on ultrasound. The ultrasound can't penetrate the bone on top of the manubrium, which makes it difficult to assess for central neck lymph node metastasis. The still image is on the left-hand side, so multiple metastatic lymph nodes in the upper mediastinum. And over on the right-hand side show multiple small lymph nodes, which are metastatic in the central neck. These metastatic lymph nodes in the low central neck and high upper mediastinum can typically be accessed through the regular thyroid incision, but knowing about them before the surgery is really important. Next slide, Liz. So based on this patient's preoperative workup, the patient has metastatic papillary thyroid cancer stemming from a left lobe primary tumor, and then she has metastatic lymph nodes in both the central and bilateral lateral necks. So in order to treat her, she's going to require a total thyroidectomy with bilateral central and bilateral lateral neck dissection. So the operative standards recommend a compartment-oriented lymph node dissection in these patients when they have cervical lymph node involvement. The definition of a compartment-oriented neck dissection is using the anatomic borders in the lateral neck, which includes levels 2, 3, 4, and 5, and for the central neck in levels 6 and 7. This is in contrast to doing a selective neck dissection or quote-unquote berry picking, just trying to remove the metastatic lymph nodes, but instead removing the lymph node levels in block, including both the lateral and central neck. So now we're going to discuss some of the operative steps for the compartment-oriented dissection, starting with the central neck. Next slide, please. These two figures illustrate the central and lateral neck lymph node compartments. The image on the left-hand side delineates the central neck. The anatomic borders of level 6 are the hyoid bone cranially, the nominate artery caudally, the common carotid arteries bilaterally, the prevertebral fascia posteriorly, and the strap muscles anteriorly. The level 7 lymph nodes are typically those upper mediastinal lymph nodes. These are going to be below the level of the nominate artery where it crosses in front of the trachea. Part of level 7 can be accessible through the regular thyroid neck incision, but those very deep down mediastinal nodes may not be accessible. The lateral neck over on the right-hand side includes levels 2, 3, 4, and 5. The most common location for metastatic lymph nodes in the lateral neck is going to be levels 3 and 4. So when you do a lateral neck dissection, a compartment-oriented lateral neck dissection should include levels 2A, 3, and 4, with inclusion of level 2B and 5 if they're involved with metastatic lymph nodes based on your preoperative imaging. Next slide. So we'll first start with the central neck dissection. The two images on the left are taken from the ACS Operative Standards textbook. This demonstrates that most of the lymph nodes within the level 6 tend to be below the level of the thyroid gland. The exception of this is the Delphian lymph node, which sits above the isthmus of the thyroid gland, very close to where the cricothyroid cartilage is. When you're doing a central neck dissection, you should include all the lymph nodes from the hyoid bone down to the innominate artery. Dissection along the anterior surface of the recurrent laryngeal nerve, starting from its insertion point into the larynx, down into the central neck caudally, can help you separate the nerve from the lymph nodes, which typically lie anterior to the nerve. It is important to recognize that over on the right-hand side specifically, next slide, Liz, there are some lymph nodes that lie posterior to the recurrent laryngeal nerve in the deep paraesophageal space. One more slide, Liz. This is an operative picture of a metastatic lymph node that lies posterior to the recurrent laryngeal nerve on the right-hand side. These areas need to be closely dissected during a central neck dissection to avoid leaving metastatic lymph nodes behind. If extranodal extension is present into the recurrent laryngeal nerve, as long as that nerve is functional preoperatively, you should try to preserve that nerve anatomically and functionally by removing the metastatic lymph node. Even if there's a microscopically positive margin on the recurrent laryngeal nerve, it's better than sacrificing the nerve as long as it's functional prior to surgery. This is especially true when patients have not yet had radioactive iodine therapy. Radioactive iodine therapy is pretty good at managing those microscopically positive margins. Next slide, Liz. So the images here highlight the proximity of the inferior parathyroid glands to the level 6 lymph nodes. The inferior parathyroid gland is often situated in the upper thyrothymic tract, connected to the rest of the thymus as it descends into the chest. If possible, the surgeon should try to preserve the vascular pedicle to the superior parathyroid gland, and you can leave the cervical horn of the thymus intact in hopes of preserving the inferior parathyroid glands. If that's not possible and the inferior parathyroid glands become devascularized, the surgeon should use intraoperative frozen section to confirm that what they think is a parathyroid rather than metastatic lymph node prior to auto-transplanting that lymph node. The superior parathyroid glands are usually a little bit easier to preserve on the vascular pedicle. The vascular pedicle usually stems from the inferior thyroid artery, and they tend to be situated away from most of the level 6 lymph nodes. Next slide, Liz. So now we'll spend a little bit more time on the lateral neck dissection, which includes levels 2 through 5. Next slide. So lymphadenectomy of the lateral neck can be performed through an extension of the thyroidectomy incision laterally over the sternocleidomastoid muscle. You can either do this transversely along a natural skin crease, or you can extend it parallel to the sternocleidomastoid muscle in more of a hockey stick fashion up towards the angle of the mandible. Once you raise sulpitismal flaps, the anterior border of the sternocleidomastoid muscle should be dissected and retracted laterally. This will expose the internal jugular vein as well as the nodal packets in levels 2, 3, 4, and 5. You can commence a lymphadenectomy by dissecting along the anterior and lateral aspect of the internal jugular vein, the vagus nerve, and the common carotid artery. You can either start inferiorly at the clavicle and move up, or start at the angle of the mandible and move down. When you're dissecting caudally in the lower aspect of level 4, care should be taken to avoid injury to the thoracic duct, where it empties into the junction between the internal jugular vein and subclavian vein. It's often very difficult to notice a thoracic duct leak at the time of surgery because the patient's been MPO, and the lymph leak will be very clear as opposed to milky when the patient's eating a regular diet. Once you've dissected the level 4 lymph nodes off the subclavian vein, you're going to develop a plane anterior to the scalene muscles. Typically, the phrenic nerve will run on top of the anterior scalene muscle, and you need to leave this posteriorly to the nodal packet as you move up into level 4. The brachial plexus is typically much deeper than the phrenic nerve. It's typically not visualized during a typical lateral neck dissection, but care should be taken to obviously preserve this. Next slide, Liz. I'm sorry, one more slide, Liz. As you continue the dissection up from level 3 up into level 2, the facial vein, which is one of the main takeoffs anteriorly from the internal jugular vein, is a nice landmark. It's important to recognize that there are going to be some lymph nodes, especially in level 2, that are situated anterior to the internal jugular vein, typically above the facial vein takeoff. You need to make sure you remove these in addition to the lymph nodes lateral to the IJ to prevent missing some metastatic lymph nodes in this area. When you dissect posteriorly, especially in level 5, the spinal accessory nerve can be visualized as it runs down the trapezius muscle. If you're using recurrent laryngeal nerve monitoring at the time of your thyroid surgery, you can use the motor stimulation on the recurrent laryngeal nerve monitor to help you identify the motor nerves when you're working out in the lateral neck. The uppermost border of level 2 is going to be the digastric muscle, which is typically easily visualized as you continue dissection up the internal jugular vein. Next slide, Liz. So finally, this last slide just highlights those anterior jugular veins, which typically need to be removed. You don't necessarily need to ligate the facial vein, but you can do so if needed. Once the nodal packet is removed, you can either send this in block to the pathologist as a single specimen, or you can separate it out into the levels 2, 3, 4, and 5 on the back table. JP drains can be placed selectively based on surgeon preference, and then the palatis muscle in this can be closed. Thank you very much. We're going to turn things over to Tracy and Libby for some questions.
Great. Thank you so much to all the panelists for your expertise this over the past hour. Invite all of our attendees to go ahead and put some questions, and we'll be asking the panelist. Dr. Grubbs and I are monitoring that. So we may start with one question from the audience already. So more for Dave, but interested in hearing all of your approaches. Do you routinely request thyroglobulin washout when you're biopsying lymph nodes, even if you see cystic lymphadenopathy or microcalcifications in papillary thyroid cancer? And I guess my adjunct to that would be sort of, how you interpret those thyroglobulin washout levels for our audience.
Great, I can start. Those lymph nodes we showed on the ultrasound and the CT scan are pretty obviously positive. Doing a confirmatory FNA can help confirm the diagnosis of metastatic lymph nodes. I typically will send at least one of the FNAs for a thyroglobulin washout. You don't really know what the cytopathology is going to show until after the pathologists have had a chance to look at the slides. Typically, that thyroglobulin washout in positive lymph nodes tend to be extremely high. The cutoff seems to vary between different studies. I've read anywhere from 3 up to about 7, but almost every time I've biopsied a metastatic lymph node, the levels are usually up in the 100 range.
Great, thank you.
Next question is from our audience is, do you always do a bilateral central neck dissection for well-differentiated thyroid cancer with clinical level 6 disease, or only one side? Or do you do a limited dissection to decrease risk of hypoparathyroidism? The age-old question. We can go for hours on this. Everybody push their dinner. Let's start. Why don't we go with Julie? Do you want to start a little on that, and then we'll get others to weigh in as well?
Sure. I don't do routine central neck dissection. I look down there, and if there was nothing on imaging and nothing clinically, and it's a low risk tumor, then I don't do that. If there's any concerning nodes, then I'll do a central node dissection, or if I'm dealing with high risk pathology.
And would you do that unilateral or bilateral then, Julie, if there's concerning disease?
Usually unilateral.
Any other thoughts from others on that, or what helps them decide whether they're going to do a unilateral or bilateral central neck?
Sometimes, Libby, I'll use frozen section to help guide that. I mean, I think some of it depends on what you're seeing intraoperatively. I mean, you're talking about a situation where you already have a unilateral confirmed disease. So I think in those situations, and you're doing a total thyroidectomy anyway, I would typically oftentimes sample a lymph node or two on the contralateral side. And if you do get a frozen section that's positive, then I would do the bilateral central compartment dissection. And I think it also, David outlined very nicely some of the intricacies of how to do that central compartment dissection, particularly as it relates to that inferior parathyroid gland, which is a lot more variable than the superior gland. But if you've already identified that inferior gland and you kind of see it in the thyroidothymic ligament, and you can kind of rotate it as he showed out of the way, that really gives you a lot more freedom to do that central compartment dissection without worrying as much about the permanent hypoparathyroidism. We know that temporary hypoparathyroidism is probably going to be a bit more common when you get a bilateral central compartment dissection. But I think that if it just lasts for a week or two and it's temporary, it's usually not that big of a deal.
I think one important thing to consider is when patients have lateral neck disease, they often don't have skip metastasis where it skips the central neck. So if you have lymph node metastasis out in the lateral neck, I typically always do a central neck dissection, at least on that same side, because they'll often have some metastatic lymph nodes in the central neck, especially when they have level 3 and level 4 lateral neck nodes. Tracy, you're muted.
Trace, you're muted.
Sorry. To follow up on that discussion, if you do see, if you do have bulky lymphadenopathy near a parathyroid gland, or, how do you manage that? Do you always reimplant it? What is your thoughts on parathyroid preservation in the setting of that central neck dissection?
I have a very low threshold to reimplant the inferior parathyroid glands, especially in bulky disease. It makes it very, very difficult to maintain the blood supply. Confirming that it is a parathyroid before you reimplant it, I think, is important because they can be very hard to discern sometimes. Sometimes your fallback is going to be those superior parathyroid glands or the parathyroid glands on the contralateral side. You're hoping that they preserve those enough to be functional.
Great.
All right, here's one, Lynn. This one is a preoperative question. What is our opinion on using preoperative thyroid globulin for stratification or need for systemic staging? Is there a role?
So the official answer is no, but maybe not yet. So I think it's an area that's being looked at and evaluated. But right now, there is no role for preoperative TG levels when the thyroid is in situ. It can just really range, and it's really hard to provide any diagnostic accuracy. I think some people are using it as a way to say, okay, preoperatively, what happens postoperatively, to have a preoperative baseline and to see what it looks like postoperatively. But I think there's still some data that needs to be generated.
Anyone else have different thoughts or want to chime in? Okay.
I'll say, I know I'm not supposed to say anything, but I think it's also interesting sometimes to understand whether they have antibodies ahead of time, because when you're counseling patients, to just go ahead and let them know, we're not going to be able to use thyroid globulin afterwards, but let me tell you a little bit about the thyroid globulin antibody you have, so you're not, perseverating over this. All right. Thanks. Go ahead, Trace.
Great. Another question from our audience. For lateral neck dissections, do you routinely take levels 2A and 2B? Let me just maybe go down the panel on this. Dave, do you want to start?
Yeah, typically 2A is typical for a lateral neck dissection, usually at least levels 2, 3, and 4. Level 5s are not commonly associated with metastatic lymph nodes, and level 1 is almost never. I don't think I've ever seen that. But at least the levels 2, 3, and 4, yeah.
Mark? Do you have anything to add? Or?
Just to add to what David said, I typically, if there are metastatic level 2A lymph nodes, I'll typically take the 2B lymph nodes out when doing the level 2A. If there's not metastatic level 2 lymph nodes, if they're more, if they're a smaller lymph node burden overall, or it's mostly in the low neck, then I will just do the 2A in order to spare the sort of the trauma to the spinal accessory nerve that is part of any 2B dissection. There's obviously going to be a little bit more trauma to the nerve with the 2B than a 2A alone.
And how do you know when you've gone high enough in level 2A and 2B? Any thoughts?
I think for 2A, I think the nerve is your superior margin. In 2B, I think it's just the floor of the muscle. I think you do have to sort of be a little bit conservative when you start doing 2B, because sort of the sky's the limit. You can sort of continue digging and digging and digging. So I think just following the outline of the floor of the neck and the sternocleidomastoid muscle, and you don't really have to dig posterior to the sternocleidomastoid muscle, but just following those basic muscle outlines there.
Yeah, reviewing the CT scan intraoperatively is always a great thing to have. You can kind of evaluate where the metastatic lymph nodes are, and just want to make sure you don't miss them on the borders. That's the most common place to miss lymph nodes, is you didn't quite go far enough in level 2, or quite out lateral enough, or not quite low enough. So use that CAT scan to make sure you got every single last lymph node out of there.
Libby, now you're muted.
I'll go with the next question. These are great questions. Thank you all, audience members, for these. Okay, has genetic testing changed your management of lobectomy versus total thyroidectomy? I.e., if a nodule is less than 4 centimeters, comes back as PTC on FNA, but genetic testing for a TERT mutation is there, would you do a lobe or discuss doing a total? Anybody want to take this one?
Lynn?
Yeah, so I'll take that. So I think if it's an isolated TERT, that's very rare. But I think the data is still a little bit out on sort of isolated TERT. But I think if you see TERT in combination with another driver mutation, like BRAF or RAS, there's a lot of data that suggests that this cohort is the cohort that's at highest risk for distant metastases and recurrence. Not all, but I think it's certainly high. And so I think it typically will go hand in hand with what you're seeing on imaging, what you're seeing clinically. And so typically for these patients, I would recommend an upfront total. Our endocrinologist will be anxious to give these patients radioiodine at minimum, and for long-term surveillance, especially if we already know that it's cancer going into surgery. So.
And are you getting genetic or mutational testing on all of your thyroid specimens? Like, is this something that's routine at all of your institutions?
You mean on histology or on preoperative?
Well, both, but on histology.
On histology, no. I think really, if it's clinically indicated and we think it's going to change management, then we'll get it. I think right now the accepted reasons to get it on known cancers in histology are really if you're looking at advanced cases and thinking about targeted therapies or neoadjuvant therapy. I think there's a very real role in looking at molecular prior to resection. I think the jury is still out in terms of getting molecular on nodules that are positive for PTC. Again, if they seem like they would be treatable readily by lobectomy or total thyroidectomy, depending on clinical variables, whether or not molecular testing adds anything is still a little bit questionable.
Okay. So to follow up, staying in the line of mutational testing, would a known BRAF V600E mutation influence your decision about extent of surgery? And here they're specifically asking about bilateral central neck dissection. But a known BRAF, does that change your extent of, in your mind, does that factor into your extent of surgery? Mark, you want to start on that one?
Sure. Well, I think if you have a BRAF TERT, I agree with what Dr. Yip was saying. I think that's one factor you would consider, as maybe moving you a little bit more toward the total as opposed to lobectomy. But a BRAF alone, I don't think so. I think, we know that 50 to 60% of papillary thyroid carcinomas are BRAF mutated. So I don't think a BRAF mutation alone is going to sway me at all toward either a total thyroidectomy or more or less likely to do a central compartment dissection. I tend to use frozen section quite liberally in making decisions about central compartment dissection intraoperatively, but I don't think the BRAF status would change that. The other thing about BRAF that's important to remember, it is controversial. There's a little bit of controversial data, that's been scattered throughout the literature about are BRAF mutated tumors more aggressive in some way, and do they deserve more, more treatment? I think the other thing to remember is that these tumors are not as sensitive to radioactive iodine. So, oftentimes, the argument for doing a total thyroidectomy is that you want to give the patient radioactive iodine. Well, the BRAF mutated tumors are the ones that are a little bit less sensitive to radioactive iodine. So I think that's another reason why I don't think BRAF status alone is a reason to sort of upstage the treatment to a total thyroidectomy or to automatically doing a central compartment dissection.
Dave or Julie, any different thoughts on that?
I do think it's reasonable to consider doing more surgery, doing a total thyroidectomy in these patients, and I think that it's a discussion to have with the patients and explain to them the data that we have, and that there aren't clear guidelines that we should do more based on FNA or AFIRMA or genetic testing right now, but that what we see is that we do see some of these are more aggressive tumors, and explain to them. And I think that conversation opens things up, and then you get a sense of the patient's feeling about their risk and the risk of recurrence versus the risk of complications, and you get to kind of figure out what they're more comfortable with.
Yeah, I'd agree. With the new guidelines making micrometastasis in the central neck not something that needs radioactive iodine, it means most of the time, I don't think a prophylactic neck dissection is going to give you much more information that's going to change the patient's, long-term treatment plan. It's really only those macrometastatic disease, which you're going to pick up on the preoperative imaging usually, that's going to make them need radioactive iodine. So the micrometastatic disease, people have shown there's no difference, so you don't even need to know about it, I don't think.
Yeah, great. Two different questions I'm going to try to combine into one is on cross-sectional imaging. So a question on getting cross-sectional imaging during the evaluation to help with lymph node mapping, particularly for inferior nodal disease that might be missed. And combined with that is the use of contrast with CT imaging. There was a note that a couple of patients recently had radioactive iodine delayed because of the use of pre-op contrast imaging. So I guess a question on when it's appropriate to get cross-sectional imaging, and then do you use contrast, and how do you work with your endocrinologists around managing that before radioactive iodine?
So I think for cross-sectional imaging, I think if it's going to help the surgeon, then you should get it. I think you want to make sure that you provide an adequate initial assessment and you have all the information that you need going into surgery. And so I think if you're not getting the information that you need on ultrasound alone, then get the cross-sectional imaging. And I think that often cross-sectional imaging in this situation is not helpful unless you give the IV contrast. It's nice to have the contrast to see where the blood vessels are, the relationship. And so I think if you're going to, and it's no point in getting the non-contrasted images and then get the contrast later. I mean, I think it's really helpful to have it up front. And so, I think that is a good question about the iodine. And, typically for patients with normal kidneys, they should be able to clear that IV contrast load fairly quickly. And so it should not necessarily impact the use of IV. The clearing of the iodine shouldn't necessarily deter us from getting IV contrast when we want it, but certainly I think it's a conversation to have with the endocrinologist, let them know that the patient had IV contrast, and to make sure that the patients are, of course, adequately prepared. So they usually check urinary iodines prior to giving the iodine, radioactive iodine.
I agree with Lynn. I think if you need the CT scan, deal with the contrast, and the better safe surgery will be the better outcome for the patient.
All right, this one is for Dave Hughes, asked by name in the question. In cases with extensive lymph node metastasis at level 4 on the left side, Do you think that the use of indocyanine green fluorescence could be justified for the detection and ligation under direct vision of the thoracic duct and to prevent Achilles fistula?
Maybe. There's been a few studies out there that are pretty thought-provoking. When they show the videos, you can see the thoracic duct like it's a glow stick. You can see the lymph leaking out of it. It seems so pretty when you see it. I think it's still a little bit to be determined. It is very difficult to see a lymph leak when patients are NPO. There's a little collection of fluid down there. You can't tell for sure whether it's just, coming from the thoracic duct. The thoracic duct is like a wet piece of tissue paper. It can be very challenging. So anything that can help, I'm willing to try out, but I think the jury's still going to be out for a little bit.
Does anyone on the panel use it routinely now or have tried it?
No, I would just add to what David said. I've not used ICG, but the other thing I would say is that while sometimes you do see one nice classic thoracic duct, oftentimes what you see is it's not just one duct. It's actually a whole conglomeration of sort of ducts and in branches there that you kind of have to tie off sort of a whole conglomeration of tissue in multiple passes. I haven't personally used the ICG. I don't know many surgeons who do, but I certainly have seen the reports in the literature about using it.
Right. Sorry, I just lost my place in the questions. There was a question about when indications after a thyroid lobectomy, or maybe even going ahead with total thyroidectomy for the indication of giving radioactive iodine following surgery. Sort of what are the thresholds for when your patients are receiving RAI and kind of the decision to proceed with a total?
Lynn, you want to take that one? You're smiling.
That's because if you have 10 endocrinologists, you get 10 different answers. That's why I'm smiling. So, I mean, there are very clear, well, there are very obvious times when you wouldn't, and there are very obvious times that you would, and then probably half of the cases that we see kind of fall in the middle, where it depends a little bit on, I think, the endocrinologist. So, clearly intrathyroidal cancers that are less than 4 centimeters can be treated adequately with lobectomy. Those high risk, cancers can, total thyroidectomy with radioactive iodine. I think, the ones that we don't really know are ones with maybe minimal extrathyroidal extension, 1 or 2 lymph nodes that are positive out of 5 or 10, kind of some of these cancers that have maybe 2 or 3 different features that may or may not, raise the concern about the endocrinologist. And it depends. For some endocrinologists, they would like to have the radioactive iodine to facilitate their surveillance. For some, they're perfectly comfortable watching, patients like that with lobectomy alone. So I think it really comes down to that multidisciplinary conversation and really understanding what the multidisciplinary team is going to do with patients long term, understanding the practice patterns, the comfort level of the endocrinologist, and so having that conversation beforehand is helpful with the whole team. So, and the patient, of course.
Just to add to what Dr. Yip said so eloquently, one thing that we haven't talked about is, what's the threshold to do completion thyroidectomies, which I think is a little bit higher threshold than doing sort of the upfront total thyroidectomy. And oftentimes that we'll do a thyroid lobectomy, and there will be a couple of micro metastatic lymph nodes in the specimen, or tumor with a little bit of minor extrathroidal extension. And in our multidisciplinary group, we have not taken those patients back for completion thyroidectomies. The patients that in my practice where I've tended to need to do a completion thyroidectomy is really it's more of the, if you have like a large Bethesda 3 or 4 thyroid nodule that comes back is on the final is like an angioinvasive, oncocytic or follicular carcinoma. That angioinvasion really tends to really be a clear deciding factor if there's any significant degree of angioinvasion for wanting to do a completion and giving radioactive iodine. So that's one example where I've seen completions needing to be done.
All right. Next question. Where do you auto-transplant parathyroids? Julie, where do you put them?
The sternocleidomastoid on the ipsilateral side around the level of where the parathyroid would be, and then I put a clip and a suture.
Ipsilateral to the side it came out?
Right.
Like whichever gland was devascularized?
Yeah.
And the question I always have, not that I've ever taken out 2 parathyroids, I'm asking for a friend, but do you put them both, if you had 2 parathyroids confirmed, would you put them both in the same pocket, or would you make 2 separate pockets? What's your way of doing it?
I don't know. I think I'd probably do 2 separate pockets, maybe a lower and an upper, so I had 2 different sites. In case you ever had hyperpara, you could have them distinct entities.
I definitely admit that I've implanted multiple parathyroids on multiple occasions. And
you're the friend, Mark. That's right.
Exactly. I'm your friend. I put them in 2 separate pockets. So.
Perfect. All right. Thank you, guys. Hey, Tracy, I think we got them all, didn't we?
I think was there one more?
I think we did.
Yep.
Most of them. So why don't we, in the last little bit, everybody loves a little case to end the day. If we can go to the next slide, Liz, and we'll just do a case, and we'll see if we get this one done, and we'll go from there. So I have a lovely 47-year-old, this is a 47-year-old woman, sorry, with a palpable thyroid nodule found by her primary care physician. Otherwise healthy, no medicines, no family history of thyroid cancer. Review systems may be significant for mild increased hoarseness over the last 3 years. She had to ask her husband. He was like, maybe, I don't really know what you're talking about. But she's like, yeah, no, I think I've had a little increased hoarseness. And then normal thyroid function. So Lynn, she shows up in your office, and what would you like to know, and what would you like to do next?
Yeah, so I think just like dysphagia, some raspy voice changes seem very common in patients, especially when you query them about it. And I think it's important to hear how the voice sounds, to see if they've had surgery in the neck before, any kind of predisposing risk factors that would raise your concern about a recurrent laryngeal nerve palsy or paralysis in a prior procedure. I think the most common reasons why this likely happens are things like sinus issues and reflux and allergies. And so I think, it's not, and sometimes even age-related changes. And so I don't know that it's all necessarily related, but I think if there's any concern still, especially with a diagnosis of thyroid cancer, then I would either do a ultrasound laryngeal exam at the time of the visit, or send them to for direct laryngoscopy with our ENT colleagues.
So out of curiosity, how many on the call, how many are using ultrasound to evaluate vocal fold function? Right, so we had 2. I guess 2.5, Dave, I don't know what that is. Here you are.
It's a nice way to take a look. It is really hard to see the cords in males, especially older males, when they have a little bit of calcification in the thyroid cartilage. If there's ever any doubts, the gold standard still remains, I think, the flexible laryngoscopy or direct laryngoscopy.
Okay. Awesome. So you did you did evaluate her cords. They look fine. She had a little bit of what looked like erythema from reflux, and you're going to start her on a PPI for that. So we went ahead because she came to you that day. Oh, I'm trying to move my slides and I can't. Go ahead and go to the next slide, Liz. So got an ultrasound that day, and it showed this nodule, which was a 1.8 by 3 by almost 2 centimeter nodule that transverse and long. And then if you go to the next slide, it had some flow throughout it. And this was really one of the most representative pictures that there was. There was no evidence of an invasion of the strap muscles above. and on any of the pictures. No concerning adenopathy in either the anterior neck or the jugular territories, and no lesions in the contralateral lobe. And given that it was this solitary nodule of this size and these characteristics, an FNA was performed and came back as papillary thyroid cancer. And so, you know, based on this, does anybody want any, well, we can go to the next slide. I think the question there is, anybody need any additional imaging or information based on what I've given you? You happy? Okay, next.
I may consider a CT neck. I think I tend to look for reasons to get a CT neck on patients. I think this was already mentioned by Lynn and David. You know, obviously patients who've got macroscopic lymph node metastasis is one indication. This patient doesn't have that, but sometimes, you know, if a tumor gets to around 3 centimeters, I'll go ahead and get a CT. There's not a lot of data for that, but I will do it. Oftentimes, 3 centimeters is my personal cutoff to get a CT.
And is your concern here because of the size of it? Are you looking for direct invasion, or because of the size of it, you're thinking there could be lymph nodes involved that you're not seeing on ultrasound? What are your thoughts?
Yeah, both. I think I think the risk of lymph node metastasis goes up, but also, yeah, I mean sometimes. You know, the CT gives you, obviously a lot of people are very facile with ultrasound and can get a better look with ultrasound than CT, but CT gives you a different way of looking at it, and sometimes you can maybe appreciate some of the extrathyroidal extension that may be present on a CT. Although a lot of times the you know, the extrathyroidal extension is also an intraoperative finding as well, but it can give you a little bit more information in some cases.
So then the question would be, what is your initial surgical approach? And I will say that the patient, this is a real case, had heard really not excited about surgery, and asked about potentially could we observe this, because he'd heard that sometimes surveillance is a possibility. And he also stressed again that he was very concerned about being completely thyroid hormone dependent. So he just wanted you to know those two things. So Julie, given this in mind, these thoughts, how would you counsel him about what would be your initial approach to managing this 3 centimeter PTC?
Yeah, so I would tell him that there are people observing papillary thyroid cancers, but that it has to be done in a really controlled setting where someone's going to look at consistently the volume, the dimensions of the nodule, and really be careful about it. And he has to really commit to that pathway. And we don't currently, where I am, have that full surveillance set up. In terms of a lobectomy, I think a lobectomy would be reasonable given the information we have at this point on this patient. I would also tell him, though, that I think even with a lobectomy, he's probably at fairly high risk to be ending up on thyroid hormone replacement with a starting TSH over 3. And so back in the day, we were kind of taught that everyone ends up on thyroid medicine, maybe 50% of lobectomy patients. But I think we're starting to realize now that we can be a little more informed with our lobectomy patients, telling them if you have a high TSH or some autoimmune disease or a low volume contralateral remaining lobe, there's a much higher chance you're probably going to end up on medication. And so, being that he's already bringing up the medication, I think we should have that discussion early on as well.
Yeah, that's a great point. There's a difference between being thyroid hormone dependent and needing to be on thyroid hormone after you have surgery for thyroid cancer, and I think that's a big distinction to make with patients so they understand it. So wonderful. Is everybody okay with the start of doing a lobectomy? Anybody want to do anything differently? No, we're good? Okay. So we go to surgery, and then if you'll go to the next one. So this is just my standard template on for findings at operation. And At the time of surgery, no macroscopic presence of extrathyroidal extension to the strap nodes, strap muscles or other areas. But the left paratracheal nodes, when you get in there, did have a question of concern for metastatic disease. A little enlarged, not the large one that has like the name tag that says I'm metastatic disease, but concerning enough that you sent it for frozen section, and it did return as papillary thyroid cancer. Is that enough information for you to do something different? And Dave, what would you do with that information?
So these are presumably macro metastatic, since you could visualize that they were metastatic at the time of surgery?
Well, I mean, it was large enough that I said, let's send it. Again, you know, sometimes you just get enlarged nodes and you're just, you don't know exactly. Again, sometimes they're the ones you show the med student, like, this is metastatic disease. I would give my first child for this, but other times there's not. And this is one of those ones that it was just enlarged enough that I was concerned that I sent it.
Yeah, I think I would interrogate the central neck for additional metastatic lymph nodes, especially the left central neck. You're already on that side. You might as well take care of them while you're there. Whether you convert to a total thyroidectomy, I think that's a great question. You know, it depends on his kind of the conversation you have with them prior to the surgery. Do you always mention that it's going to be a possible total thyroidectomy? I think that's important. You know, his long-term prognosis is probably going to be the same either way. So that might be something you need to consider, maybe talk to the family about.
Anybody do anything different?
I was going to say I would say the same thing as David. I would complete the left central, and assuming there wasn't anything else concerning that made me move toward total thyroidectomy. I don't think sort of the finding of the disease microscopically on frozen section would automatically move me toward a total.
If you find a bunch of other metastatic nodes when you're over there, I'd probably convert to a total and clean out the other central neck too.
Yeah, these are ones that I've actually started asking the person in frozen section, can you just give me a size on it? Because sometimes it'll be 2 millimeters. Like, I'll have thought I've taken out a concerning node, and it's just your run of the mill. So I think that's a great point that you guys are making. So in this setting, all right. So in this setting, if it's something that you're questionable about, sounds like you can still do the lobectomy with the ipsilateral central neck side. To your point, Dave, if I continued to dissect and then I saw 3 or 4 more nodes that were concerning, that's when you guys would change. And in that setting, just to go back to one of the questions our individual, one of our persons asked, you're going to do a total thyroidectomy in that setting. Then remind us again, what's going to make you decide whether to do a bilateral level 6 lymph node dissection, meaning the contralateral and the ipsilateral side versus just that ipsilateral side? Is there something, Julie, will you be doing a bilateral in that setting, or is there still decision making to be made based on what you see?
I think it's decision making based on what you see, but if you're planning on staying with just the lobe, then I think you dissect just that side, because I don't think you want to cross midline unless you're committing to crossing midline.
But if you're doing a total thyroidectomy, if you found the malignancy on that ipsilateral side made you say this is multi lymph node positive gross disease, and you were doing that total thyroidectomy, in this setting, Mark, what would make you say I need to do a bilateral central neck?
I would often I think there's 2 things. I think you take into account sort of the parathyroid status. You've already dissected the left side, so you already kind of know, if you've preserved those 2 parathyroids in situ, you may have a feeling that you can be a little bit more aggressive on the right side. But the other thing is I would probably make a couple of spreads as I was doing the total thyroid. I'd probably see if there's a couple lymph nodes that are right there. I may send 1 or 2 for frozen, and I would base the decision on that frozen. That's often how I do it.
And then let's say that let's erase this, and let's say we were taking this person with the 3-centimeter papillary thyroid cancer surgery, and what you found was, go to the next slide, Liz, that in this setting there wasn't any concerning lymph nodes, and there was no invasion into the strap muscles, but posteriorly that 3-centimeter lesion or tumor seemed to invade the recurrent laryngeal nerve about 1 centimeter proximal to the laryngeal inlet over about an 8-millimeter area. How would you approach that finding at surgery? Lynn, you haven't. I got to get back to you.
Okay, I'm enjoying the discussion. So was I think it's important to know if the nerve was, if the vocal cords were working prior to surgery, because that ultimately does impact what we do at this point. So if the nerve is already out, you know that there's no function on that side prior to surgery, then I would be a little bit more likely to sacrifice the nerve and then reconstruct it in some way to at least maintain some tone to the area. If the nerve was functioning and there's no concern about the vocal cords prior to surgery, then I would shave the tumor off of the nerve and preserve the nerve and hope that the radioactive iodine would clean everything up. But in that situation, you would be doing an upfront total, right? I think if you're shaving out the nerve for sure.
Okay, so there was functioning before. So in that setting, because of that invasion, that would lead you to say do a total thyroidectomy in this setting. Okay.
Yes, I think in either situation. So if you had to sacrifice the nerve, you know that it's an aggressive tumor with a high risk of recurrence, and so you would be doing an upfront total to give the radioactive iodine for sort of that adjuvant setting. If you were shaving it off the nerve and you know that you've left some microscopic disease behind, you would still need to give radioactive iodine to hopefully clean up that margin, so to speak. And so you would still be doing an upfront total in order to facilitate that radioactive iodine. So in either situation, I'd be doing an upfront total.
Any other thoughts or insights on nerve invasion? Dave?
This one, the nerve monitor, I find is very helpful. It can tell you if that nerve is still functional after you've spent 20 minutes or 30 minutes trying to get the tumor off of that very small nerve. It also helps to confirm that the nerve on the contralateral side is functional at the end of the surgery. It's really important to have one functional nerve once you're done with a total thyroidectomy.
And then Mark, for you as well, how do you know when you need to move from shaving it to resecting it?
I think, David mentioned earlier, I mean, one of the most important things is the status of the nerve preoperatively. If that nerve is functional preoperatively, you're gonna want to try to preserve it if at all possible. If it's not functioning preoperatively, then I think it's a pretty easy decision to sacrifice it. But assuming it is functioning preoperatively, I think, looking at the type of invasion of the nerve, if it's just stuck to the epineurium, and the nerve itself is not, particularly like enlarged and discolored, whether it kind of, sometimes the nerve involvement can have this sort of white, sclerosing appearance, or sometimes it can be sort of a more, darkly colored to it. But if the nerve is grossly enlarged and discolored, I mean, that's going to be a situation where you're probably going to have to sacrifice that nerve to get the tumor out. But if it's just really stuck to the epineurium, I think shaving that off, even, sometimes depending on the situation, even shaving a little bit of the epineurium off can be done, with the tumor. But and then, as was mentioned, I think, leaving microscopic disease there on that nerve is acceptable in a case where you've got a differentiated thyroid cancer and you're going to give radioactive iodine to preserve a functioning nerve.
All right. And with that, Tracy, you want to close this out?
Yeah, I think we're at the end of our 90 minutes. Thank you to all of our panelists. It was a great discussion and presentations today. And thanks to all of our attendees for joining. And I believe that this session will be online in a couple of weeks for everyone to see again. So thank you all. Have a great night.
Thanks, everyone.